Thank you, Laura. Thank you for the introduction. So as Laura says, I'm going to be talking about a programme of work that we've been doing in the Crab Lab at City University of London, looking at using tablet-based tests of visual function in a diabetic macular edema clinic waiting area. And this project was a collaboration with Moorfields Eye Hospital in London. So a bit of background to start off with. If I can change my slide. Here we go. So a bit of background. Diabetic eye disease is a leading cause of preventable vision loss in working age people. It affects about a third of people with diabetes worldwide and is responsible for about 1 in 20 cases of sight impairment and severe sight impairment registrations in England and Wales. The form of diabetic retinopathy that we're interested in for the purposes of today's presentation is called diabetic macular edema. In this form of diabetic retinopathy, the macula at the center of the retina thickens or fluid builds up underneath it, and this can result in central vision loss. And diabetic macular edema, which I might refer to sometimes in the presentation as DME, is considered a sight-threatening form of diabetic retinopathy. It's typically treated with injections into the eye, which stabilize vision loss, and depending on the drug used, these may be required more or less frequently. Our recent systematic review identified a number of areas of visual function to be particularly problematic for people with diabetic retinopathy. These particular areas were reading print, mobility, work, medication adherence, face recognition, and watching television. However, despite the differences in clinical presentation between diabetic retinopathy as a whole and diabetic macular edema, the impact of diabetic macular edema specifically on everyday visual function is quite scarce. In addition, the majority of studies identified in the systematic review relied solely on patient-reported outcome measure questionnaires, or PROMs, to assess the impact of the condition. And there are several limitations to the use of PROMs alone to assess the impact of a condition on a person's everyday life. So first of all, questionnaire results might be affected by a range of psychological factors, such as personality, past experience, and as such are unlikely to reflect a person's true functional ability. And secondly, PROMs can be burdensome for the patient to complete, and we know that readability in particular can be an issue and might exclude certain patient groups, leading to them being underrepresented in the literature. So another way of testing a person's ability to perform everyday tasks is to observe them actually doing the task and assessing their performance. And these are the most direct measures of assessing visual function, and actually the least often used. And recent or relatively recent advances in technology have meant that performance of everyday tasks can be simulated using computer-based surrogates of real-world tasks. And this type of test permits the researcher to observe a person performing a task designed to be as similar as possible to doing the same task in the real world, whilst allowing for a controlled experimental environment. An advantage of these methods is their objectivity. And we've been developing this kind of task and validating these in the Crab Lab at City University of London for some years now, and this was the subject of my PhD. And if you're interested in learning more about some of these tests, I've put some of the links to the papers or paper titles up on the screen here. And I would also recommend checking out Bethany Higgins's poster at this year's BCOVS. She presented it earlier today, and it's still available on the website if you want to go have a look. However, the equipment typically required for these kinds of tests is often bulky, and the tests themselves are often quite time consuming, making them appropriate really only for lab-based research. So ideally, rapid tablet-based versions of these kinds of real-world measures would be much more clinically applicable to use as patient-centered outcome measures in clinical trials, but also to have the potential to be done either at home or in hospital waiting areas to provide clinicians with additional patient-relevant information. And as such, there's actually a growing body of research on the use of tablet-based apps to utilize time spent waiting in hospital clinics. And we know that diabetic patients in particular typically spend several hours waiting in hospital outpatient clinics per year. So completely not relevant, not related to ophthalmology or diabetes, but an example of this is some researchers have developed an educational app with the, I think, quite brilliant name of the Smoker Face app. So this app is aimed at smoking cessation and shows participants what their face would look like after several years, depending on whether or not they continue to smoke. And this tablet-based app was left out in outpatient clinic waiting areas for patients to engage with as they waited for their hospital appointments. Closer to home, in the Crab Lab, we've developed a portable tablet-based visual screening tool, the eye catcher, which has been used in glaucoma clinic waiting rooms, and more recently as a home monitoring tool. And actually Tamsin Callahan and Peter Campbell will be talking about this in their talks in the next talk session at this BCOVS, if you're interested in hearing more about this. We've also been working on turning our lab-based tests of everyday visual function into tablet-based tests that can be used in the real world. We published the validation study for these tests late last year, and since then we've been investigating their feasibility of taking them out into the real world, and that's going to be the subject of my talk today. So the aim of this study was to assess the feasibility of conducting tablet-based vision tests in hospital clinic waiting areas, and in addition to test the hypothesis that diabetic macular edema severity is associated with performance on tablet-based surrogates of everyday tasks. In order to do this, we recruited 61 participants from diabetic macular edema clinics at Moorfields Eye Hospital in London. And these people had a median age of 63. And if you look at the average visual acuity, so this is recorded in logMAR, and you can see that even in the worst side, the average visual acuity is actually relatively good. We also graded participants' DME severity according to the International Clinical Classification of Diabetic Retinopathy Severity of Diabetic Macular Edema scale. And using this, 28 of our participants had mild DME, 24 had moderate, and 9 had severe DME. And all participants completed 2 tablet-based tests of everyday visual function, and both tests were conducted on a Microsoft Surface, which is a touchscreen tablet computer, and participants were tested binocularly in order to kind of simulate the real-world experience as much as possible. So the very first test we did with participants was a face recognition task, and this was based on previous work by fellow BCOVS committee member Andrew Logan and colleagues, and this version of the test was programmed by our co-author on this study, Ian Wilson. In the test, participants were presented with 4 faces, 3 of which were identical, and 1 of which had been digitally manipulated to look different from the other 3. Participants were asked to spot the odd one out and to touch it on the screen. So, so hopefully in this example, you'll be able to see that is this face here on the right-hand side. So as the test progresses, the difference between the digitally manipulated face and the other faces becomes progressively smaller, so that the faces presented at one time look more and more similar as the test goes on, until eventually we reach a point at which the differences between faces are no longer distinguishable, and participants are unable to tell the difference between any of the faces shown. And this is the endpoint of the test, and we call this the face threshold. So as I said, the task becomes more and more difficult as it progresses. So here's an example of a slightly more difficult one. So those of you who are quite good at still face discrimination might see that it's the one on the right-hand side here. And here's an even more difficult one. This one's beyond my face threshold. I'm not able to differentiate between these faces. And then the second task that participants were asked to complete was a visual search task, also based on the touchscreen tablet. In this task, participants were shown a target object, and this was bounded by a box in the center of the screen. So in this example, it's the little camera there. And then they were asked to find the matching object from an array of photographs of object, whilst that reference image remained in the center of the screen. Once participants found the target object, they touched it on the screen. So in this example, it's up here. And the outcome measure for this task was search duration, so how long participants took to find the target object in seconds. And we did 22 trials of this, and the same 22 locations were tested each time. So the reference image was always in the center, and then the target image would appear in one of 22 locations, which were the same for all participants, but shown in a random order for each participant. So we move on to the results now. I'm just going to spend a few moments explaining this chart. If we have a look again at the original array that I showed you, as I mentioned, 22 trials were presented for each participant, and the same locations were tested for each participant. So these are the 22 locations that were tested for each participant. So each participant had to find the images that were situated in these locations. Now, what this chart does is the tiles on the chart correspond to those 22 locations shown in the array, along with the average time taken in seconds to find the target at each location across participants. And what we can see is that on average, search durations were longer for locations further from the center of the screen, and shorter for locations closer to the center. So if you look at the kind of very most extreme points at the kind of edges of the chart, we're kind of approaching an average search duration of kind of 3.5 seconds to some over 4 seconds, whereas the tiles in the center of the screen show an average search duration of less than 2.5 seconds. So in other words, participants were slower to find objects that were further from the center and faster to find objects that were closer to the center. And this was the case across all 3 DME severity groups. So if we move on to the overall results now. So first of all, for the visual search task, the chart here shows the average search duration in seconds along the x-axis, and the box plots show the median, interquartile range and range of search durations for participants split by DME severity. The overlaying dots show the median search duration for each individual participant across the 22 trials. And what we can see is that individuals with severe DME had longer search durations on average than those with mild and moderate DME. And this was statistically significant. The annotated dashed line on the plot shows the 99% normative limit for search duration set by visually healthy participants found in our validation study for these tests. So we can see that the majority of DME participants, regardless of severity, actually performed worse than this 99% normative limit, and all participants with severe DME performed worse than the limit. If we move on to face discrimination now, it's quite a different story. There was no significant difference in performance across severity groups, and very few participants fell outside of that 99% normative limit that was set in the validation study. And I will speculate a bit about why we think this might be the case later on. Before doing that though, after participants completed the tests, they were asked if they were to describe each task using 3 words, what would they be? So now I'm showing a word cloud, showing the words used by participants to describe how they found the face discrimination task. And in this chart, the size of the words presented represent the number of participants to use that word to describe the test. So the larger the word is, the more participants use that word to describe the test. And we can see that for the faces test, there's really a kind of a mix of positive and negative adjectives here. So we've got words like good and interesting, but we've also got words like challenging, difficult, and hard coming up as some of the most frequent words used. In contrast, for the visual search task, we can see straight away in this word cloud that the majority of kind of large standout words are much more positive adjectives, so things like enjoyable, fun, and good. So just to summarise, going back to our initial aims, we wanted to find out if it was feasible to conduct tablet-based tests of real-world visual function in hospital clinic waiting areas. And we found that, yes, it definitely is. And this could provide clinicians with meaningful information about how a patient's condition might be impacting on their day-to-day activities and quality of life. We found the tests to be quick, they were acceptable to patients, and the majority of patients actually enjoyed carrying them out and kind of likened them to doing some kind of game. And very importantly, all tests were completed by the patient themselves with minimal operator input and on a portable tablet device. And this means that, that these tasks have the potential to be used in home monitoring of patients, and the implications of this are particularly useful and timely in light of the current COVID-19 pandemic. The second aim was to ascertain whether performance on tablet-based surrogates of everyday tasks worsens with DME severity. And what we found was that that certainly visual search duration increased with DME severity. So that's a yes for does performance on tablet-based tasks of visual search worsen with DME severity. And this is particularly a particularly useful finding because we know from previous research that visual search is an important visual task in itself, but it's also a useful indicator of mobility and ability to perform other everyday activities. However, we didn't find any association between DME severity and face discrimination performance. And this puzzled us because results from self-report of people with DME suggest that people with DME do struggle with face recognition. And we believe that perhaps a smaller viewing angle is required to reproduce these reported difficulties. So either having participants sit further from the screen or presenting smaller faces potentially. So to conclude, we found that portable tablet-based tests are quick, acceptable to patients, and can be feasibly performed in a busy clinic waiting area with minimal supervision, and that visual search in particular has potential for providing clinicians with additional information about functional deficits, not in text by current conventional tests. Just like to thank all of my co-authors and fellow Crab Lab members. If anyone wants to access the tests described in this presentation, they are freely available online, and I've put the links on this slide. And finally, thank you all for listening, and I'm happy to take any questions now.
Thank you, Deanna. That was a very nice talk, very nicely presented, so thank you. We don't have a massive amount of time for questions. I'll read out the one that is the most upvoted, which I also really need to know as well. Which face was the odd one out in the final example? I am intrigued.
That is an excellent question, and do you know what? I should have checked, but I didn't beforehand, so I can't tell you.
So that remains a mystery. It
remains a mystery. If anyone wants to know, maybe I'll post it on my Twitter later.
Okay, thank you. I'll just do two more questions. I've got some really good questions here. Have you tackled the regulatory aspects of making such apps clinically available?
No, and that I think that would be a major challenge certainly into getting them into clinics. Yeah, a very, very good question, and a real kind of issue that would be a very important one to consider if this were to kind of be rolled out as a kind of standard, standard activity to be done in clinics.
Yeah. Okay, and last question for you, which I also think is a really good question. Is there a major learning effect as subjects repeat the task? If so, this could be a major factor for longitudinal home monitoring.
And that's another great question. And we haven't found a major learning effect. As I said, we did this as we did the validation study kind of last year, and we had participants complete many more trials of the tests, and we conducted repeatability tests on them, and we didn't find a major learning effect.
Okay, thank you, Deanna. So I think that's all we've got time for today. Thank you so much for your presentation and for answering your questions so well.
Thank you.